So today's topic is CSF Rhinorrhoea. Learning objectives mainly the etiologies of CSF Rhinorrhoea, common sites of CSF Rhinorrhoea, investigations to be done in cases of CSF Rhinorrhoea, and surgical approaches for the repair of CSF Rhinorrhoea. Firstly, the basics. CSF is a clear, colorless body fluid found in the brain and the spine, produced in the choroid plexus of ventricles and reabsorbed by the arachnoid glands. Then it is acting as a cushion for the cortex, providing mechanical and immunological protection to the brain. Total volume is about 90 to 150 ml and normal pressure is about 50 to 150 millimeters of water. Now, coming to the basics again, the circulation of the CSF. Circulation of the CSF. And these are the two lateral ventricles. This is the third ventricle, and this is the fourth ventricle. Diamond shaped fourth ventricle. Now, choroid plexus at the two lateral ventricles, third ventricle, as well as the fourth ventricle are there. CSF being produced from all these choroid plexus. Now what happens? This is the foramen of Monro, through which the CSF being produced at the lateral ventricles passes to the third ventricle. Then from third ventricle via the aqueduct of Sylvius or ITER, the CSF gets drained into the fourth ventricle. Now from the fourth ventricle via the median foramen of Banerjee and the lateral foramina of Luschka, the CSF gets drained into the subarachnoid space over the brain and the spinal cord, from where it is getting reabsorbed into venous sinuses blood by these arachnoid granulations, mainly in the superior sagittal sinus. Now, this is the same picture being depicted over here, where the CSF being produced by the choroid plexus by the first and the second ventricle, getting into the third ventricle via this foramen of Monro, from where the CSF getting drained into this fourth ventricle via this aqueduct of Sylvius, from where via the lateral foramina of Luschka and median foramen of Banerjee, it is getting secreted into the subarachnoid space in the brain and around the spinal cord, from where it is being reabsorbed into the superior sagittal sinuses or in other cerebral venous sinuses via these arachnoid granulations. Now, CSF is secreted at the rate of about 20 ml per hour, that is 300 to 350 ml per day. Total CSF request in a day for about 2 to 5 times. Thus, the pressure rises on coughing, sneezing, nosebleed, blowing, straining on stools, or during heavy weightlifting. Pathways of CSF Rhinorrhoea. Very importantly, from the anterior cranial fossa, the CSF getting drained via the frontal sinus or through the ethmoidal sinus of the plate or through the sphenoid sinus during CSF Rhinorrhoea. Next, it may also get drained via sphenoid sinus or via the mastoid ear cells or middle ear into the eustachian tube from middle as well as from the posterior cranial fossa. Why does we require repair in a case of CSF Rhinorrhoea? Because firstly, social stigma, yes, socially troubling symptom. Secondly, risk of meningitis or other intracranial complications may be there. That's why we may require a repair in a case of CSF Rhinorrhoea. Etiology, firstly, it can be traumatic due to skull-base trauma, can be spontaneous, can be due to meningoencephalosis, can be iatrogenic also. So firstly, in this very picture, we can visually well understand there is a nasal discharge coming out, or rather to say dripping out of nose in a case of CSF rhinorrhea. So firstly, traumatic. 2% of head injuries, even 12 to 30% of skull base fractures may have traumatic CSF rhinorrhea as a complication. Mostly it is a result of blunt trauma, mostly heal with conservative management within 10 days. This is very important. Traumatic CSF rhinorrhea mostly heal within 10 days with conservative management. Bony spicules, okay, bony spicules continue to hold the edges apart, persist for a longer time, need surgical management. Common sites are fovea ethmoidalis, followed by sphenoid, followed by posterior table of the frontal sinus. Whereas when it heals spontaneously, only the sinus mucosal aspect of the defect closes as dura does not regenerate, producing a relatively fragile closure. This is important. The closure which occurs spontaneously is fragile enough. The layer may erode spontaneously by the pulsatile effect of the brain or inflammation within the nerves. So now the conservative management might be challenged towards a more active intervention policy. That was traumatic. Next one is spontaneous leaks. Spontaneous leaks are mostly idiopathic in nature, most commonly at the region of cribriform plates, ethmoid root, and lateral wall of sphenoid sinus. There may be a leak. Now, if there is a leak in the cribriform plate, it may occur due to dilatation of the dural sheath around the olfactory fibers. Then, sphenoid sinus leaks are mostly due to well pneumatized sphenoid sinus or the arachnoid convolution in the floor of the middle cranial fossa. Now, most of the patients have undiagnosed benign raised intracranial tension, preoperatively diagnosed empty sella, and enlarged ventricles or diffuse erosion of the skull base. Lastly, it is associated with middle-aged women with raised BMI, very commonly. Now, meningoencephalocele. Meningoencephalocele can be spontaneous, may be congenital or acquired, or associated with previous traumatic events. Consists of meninges and dura containing CSF with variable amount of brain tissue prolapsing through the bony defect into the nasal cavity. And brain tissue contained within the encephalocele is invariably non-functional. This is very important. Brain tissue contained within the encephalocele is invariably non-functional. Iatrogenic. So frequently seen on the lateral wall of the olfactory fossa. Lateral wall of the olfactory fossa. Anterior skull base weakened by anterior ethmoidal neurovascular bundle, and posteriorly due to confusion between the anatomical relationship of the posterior ethmoidal cell and the sphenoid cells. Now, these leaks are apparent at the time of surgery and should be addressed at the time of surgery. Very important. Occurs mostly in the hands of inexperienced surgeons, obviously. Now, leaks associated with tumors. Maybe tumors causing erosion of the skull base or following induction of chemotherapy, there may be CSF rhinorrhea. Importantly, margins should be free of the tumors for successful closure. Approach to a patient with CSF rhinorrhea. Firstly, the history. There should be clear rhinorrhea, very importantly, and posturally evoked. That means if the patient tries to sit from supine posture, obviously very much clearly the patient should have the CSF rhinorrhea. Very important question is, what is a reservoir sign? A reservoir sign, actually, the CSF rhinorrhea may be increased on rising in the morning when the patient cleanses it. Very important. So fluid which had collected in the sinuses, particularly in the sphenoid, empties into the nose. That's why it is known as a reservoir sign. Very importantly, now this is the halo sign. Halo sign or the ring sign occurs very importantly when CSF mixes with blood or an on an absorbent surface, on and absorbent surface. The blood forms a spot in the center. So this is the blood in the center, and a lightly stained ring forms a halo around it. This is due to CSF. This halo sign is reliable for detecting CSF, but not at all exclusive. Obviously, this is not at all exclusive. This halo sign is also known as handkerchief sign, as because mostly the absorbent surface used is an handkerchief. Next one, how to differentiate between the normal nasal secretion or normal nasal rhinorrhea from CSF rhinorrhea. So you have to take the CSF in a container and have to send it for biochemical examinations. History, mostly in CSF rhinorrhea there may be history of nasal surgery, head injury, or intracranial tumor. Obviously that can be spontaneous in nature also, but okay. Then nasal secretions is associated with sneezing. This is not associated with sneezing rather. And nasal secretions is nasal stuffiness will be there, itching in the nose will be there, lacrimation will also be there, means the features of allergic rhinitis may be there. Now next one, flow of discharge. A few drops or stream of fluid gushes down when bending forward or straining, can't be sniffed back. Very importantly, this CSF fluid can't be sniffed back. But nasal secretions, there will be no effect on bending, can be sniffed back, no problem in that too. Next, character of the discharge. It will be most likely a thin, watery, clear, high sugar content. This is important. Whereas nasal secretions will be slimy or rather mucus stained. Next one, presence of beta transferrin, very important. CSF rhinorrhea always present. Nasal secretions, no, that is totally absent. And very importantly, that is the double target sign on the handkerchief sign, seen when mixed with the blood. No stiffening. Nasal secretion is absent totally. Handkerchief stiffens due to the presence of the mucus. Okay. CSF traces. Visible dyes like fluorescein may be used. I will be discussing about this thing. Intrathecal fluorescein injection is being done in cases of CSF rhinorrhea to detect CSF leak. Then radionuclide markers like radioactive iodine 131, serum albumin, that is radioactive serum albumin, that is RISHA, technetium 99 leveled serum albumin, even DTPA, that is diethylene triamterene pentacetic acid, and indium 111 leveled DTPA can also be used to trace CSF leak. And lastly, radio opaque dyes like metrizamide can also be used. Now, pre-operative assessment. Beta 2 transferrin, yes, always present in CSF, just confirms the CSF if present. Okay. Now, high resolution CT scan of the sinuses or T2-weighted MRI or CT cysternography or gadolinium enhanced CT cysternography, MR cysternography can be used to confirm this site of leak. Okay. Now, very importantly, thus, whenever CSF rhinorrhea patients come to us, firstly, confirm it is CSF, means beta 2 transferring or beta trace protein analysis has to be done. If negative, CSF leak is unlikely, no further imaging needed. Got it? It is not CSF. No. If positive, check for active leak or an intermittent leak. If there is active leak, HRCT PNS and skull base to be done. Active leak, HRCT PNS and skull base to be done. If single osseous defect is seen, no further evaluation is to be done, only surgical report is the treatment of choice. If multiple osseous defects are seen, then CT cysternography has to be done, which is an invasive procedure. If you suspect a case of suspicious meningoencephalocele, then MR cysternography is the investigation of choice, which is non-invasive. If there is an intermittent leaks, then again, if active, CT cysternography. If inactive, gadolinium enhanced CMR cysternography and radionuclide cysternography can be done. Now, the surgical techniques. Traditional management of CSF leaks in the anterior skull base was via an anterior craniotomy and intracranial repair of the leak. Success rate was around 70% with the loss of smell. Whereas endoscopic techniques have given a success rate of around 90% at the initial attempt and up to 97% with the revision. So endoscopic techniques have given a success rate of 90% at the initial attempt and up to 97% with revision. That's why nowadays endoscopic techniques are much more preferred than the open anterior craniotomy. So this was being done by neurosurgery people, but endoscopic repair is being done by the ENT surgeons. Now, success rate of the spontaneous etiology is the worst and are likely to recur as there can be multiple sites of weakness. Broad spectrum and IV antibiotics are given along with the induction of anesthesia and followed thereafter. So endoscopic closure of the leak. The materials used for this purpose may be free mucosal grafts, pedicled mucosal grafts, fat, fascia, mainly the fascia lata, then muscle, and the synthetic materials such as hydroxyapatite. Type of material did not appear to make a significant difference to the success rate of the closure. Okay. Techniques used maybe onlay, maybe butt plug closure, and fascia lata repair and underlating. I will be discussing about it. So now intrathecal fluorescein injection can be done for as it is used for people to find the CSF size. Procedure obviously lumbar drain placed when the patient is awake, CSF is collected. Then 0.2 ml of 5% fluorescein mixed with 10 ml of CSF and is administered back slowly over 10 minutes. Patient is kept in head down position for 1 to 2 hours and then patient is put under anesthesia. So obviously this is a time taking. Uses to diagnose a leak, disclosing its exact location, providing evidence of successful repair. Complications obviously as because lumbar paresthesia occurs, then tingling and numbness in the hands and feet may occur. Convulsions may also occur following a dye injection. Can be seen better with a blue light filter. Can be seen better with a blue light filter. Now butt plug technique. In butt plug technique, we have to first identify the leak. Then enlargement of the dural defect so that the bone rim is clearly seen. Small pieces of bone should be removed before the repair. Nasal mucosa is stripped off the bony defect for around 5 mm. The fat lobule harvested from ear lobule or greater trochanter or abdomen. Very important. These are the three different sites for fat lobule harvestment. Fat lobule harvested from ear lobule, greater trochanter, or from abdomen. Then free mucosal graft, most commonly hadad basagat gets sky flap, or a fascia lata is given with the fat plug. Fibrin glue is applied and gel foam is placed over the mucosal graft and the fibrin glue is applied. This is fat plug. I will be. So now the overlay technique. In overlay technique, the graft is placed over the defect after making the edges raw, and it is done when the dura is adherent to the defect and can't be elevated. This is very important. Okay, when dura is adherent to the defect and can't be elevated. Whereas underlay technique, where the graft is in the form of cartilage or fascia is put between the intracranial structure and the defect. Between the intracranial structure and the defect. So obviously, very importantly, rough epithelial surface faces the cranial cavity. Rough epithelial surface faces the cranial cavity, while the smooth endothelial surface faces the nasal cavity. Smooth endothelial surface faces the nasal cavity. This is underlay. So overlay, underlay. Now coming to the butt plug technique. Very importantly, the here introducing a fat plug with a specifically secured vicryl suture into the intradural space. Introducing a fat plug. This is the fat plug. Is introduced. Is being introduced. Rather, is being introduced into the intradural space with a specifically secured vicryl suture. With a specifically secured vicryl suture into the intradural space and placing traction on the suture to seal the defect as a butt plug seals the butt. So this is what is known as butt plug technique actually. Now multiple technique. Multiple technique comprises of several layers of graft materials used in the case of the huge defects like fat, like the graft, then the middle terminate is being placed. Okay. Now, so the surgery consists of these steps. Firstly, defect localization by means of any procedure, radionuclide dressing, CT cysternography, intradural fluorescent intrathecal fluorescent injection, anything. Then the defect margins have to be freshened. Then fascia lata graft being harvested from the thigh. Then that graft is being placed to seal the defect. This is the graft being placed to seal the defect, or sometimes graft. Then fascia lata can also be placed below that. Okay, and lastly surgicel and tissue glue or fibrin glue are being applied. So this is the graft of the fat. Okay, then this is the fascia lata, then this is a layer of fibrin glue. I have already said that After giving fibrin glue layer, then the surgicel of the gel form are being placed, then the fibrin glue is reapplied. So this is what is being shown over there. Now transnasal endoscopic view, very importantly, firstly what is being done, this is the meningocele defect, these are the fasciolata grafts are being placed, so this is actually the defect. Then this is the graft being placed over to there, this is the fasciolata graft, this will be placed over here. Then again this is the fasciolata graft being approached to that area. Here the fat is being fat pad, this is the fasciolata graft, and this is the fat pad is being applied. Lastly, fibrin glue application is being done. Special situations, meningoencephaloceles, very importantly, meninges and protruding brain tissue are resected up to the skull base. Dural edges are cauterized with a suction bipolar to ensure hemostasis. Assessment needs to be done whether edges of the prolapsed brain tissue are in contact with the edges of the skull base defect and whether it is adjacent to the dura surrounding it. For larger defects more than 2 cm, a second layer of fasciolata or a pedicle septal flap is being placed over the fasciolata for the tissue to hyalocate. So in this very picture we can well understand that this is the grade 0 where there is no CSF leak and intact arachnoid. Okay, this is grade 0 where only a hemostatic sponge can be applied. Grade 1 where there is a minor CSF leak with no obvious arachnoid defect. Then this is grade 2 where there is obviously a moderate grade 2 CSF leak. This is grade 1, this is grade 1 CSF leak, this is moderate grade 2 moderate CSF with visible arachnoid defect. There was no visible arachnoid defect in the grade 1, so here the arachnoid defect is being seen on, not much larger, but yes, it's seen. Then grade 3 where there is large CSF leak, no doubt in that, there is large CSF leak with large arachnoid and dural defects, usually seen in cases of the extended transsphenoidal procedures. So grade 0 requires no such active intervention, just hemostatic sponge can be applied. Grade 1 only sealant can be used to seal that minor CSF leak. Grade 2 where not only the hemostatic sponge, rather along with the sealant we have to use the fat pad. And grade 3 is the case where we may require multi-layer repair of that very defect using fat, using nasoseptal flap or fasciolata, then the sealant, that is the fibrin glue, and lastly rigid buttress can also be used. Now post-operative care, broad spectrum antibiotics for 5 days. Patient is advised not to blow the nose for at least 2 to 3 weeks post-operatively. A lumbar drain is to be kept on free drainage at the level of shoulders and to be removed after 24 hours. Patient is slowly mobilized after 24 hours. So this is important that post-operative care has to be good enough to secure the CSF leak repair very appropriately. So key points to learn from these things: CSF leak can't be closed if not identified. Fluorescein should be used in all patients. Lumbar drain should be kept for 24 hours to prevent any sudden increase in CSF pressure from putting excessive pressure over the repair. Introduction of fat has potential risk of damage to the intracranial vasculature, thus introduction has to be gentle enough. And neurosurgical opinion is necessary regarding any doubt about the section of the brain tissue. So thank you.